Today's topic is a Q&A specific to ensuring quality and fidelity to achieve outcomes. This is a discussion that happened, it feels like 2 months ago. I think it was just maybe last week or the week before. So if you're here, we'll be addressing conversations very specific and relevant to that conversation. What I'd like to do is pass us off to our first panelists, our first presenter. You may know her very well. Her name is Dana Blackwell. And I want to give you a little bit of information about Dana. If you haven't been here quite yet, Dana Blackwell serves as Senior Director of California Strategic Consultation at Casey Family Programs, CFP. In this role, Dana is responsible for leading CFP's work in the state of California to include statewide partnerships, initiatives, and systems improvement activities. So we want to say hello, Dana. Good morning. Thank you for being with us. And I'll let you take it from here.
Great. Thank you, Jess. Good morning, everybody. I'm really glad to be here because I was not able to join the learning forum for this Q&A. So I am eager to hear the questions and the dialogue that will be generated this morning. We have 2 learning forums left after today's Q&A. The next learning forum is preparing the workforce to deliver Family First prevention services. That will take place on October 19th from 10 to 1. The forum will focus on methods for counties, tribes, and community-based organizations to prepare their workforce for a comprehensive prevention program. It will address strategies for establishing a prevention mindset and developing materials and tools for staff who will provide EVP services and/or case management. So we encourage you to sign up. The final learning forum in the series will be in November, where we'll talk about how you put everything together from all of the forums that we've presented over the summer and the fall. So why don't we go ahead and get started? I want to encourage people to ask questions, raise their hands, put questions in chat. We want this morning to be interactive, and as Jess said, we want to dig deep to make sure that you all are prepared around the EVPs and fidelity. So our first panelist, and all of our panelists, you will remember from September's learning forum. First is Dan Edwards, who is a licensed clinical psychologist and technical assistance consultant for evidence-based practices. Yolanda Green Rogers is a senior policy analyst at Chapin Hall, University of Chicago. And everybody knows Kelly Winston, Chief of the Family Centered Safety and Support Bureau for the California Department of Social Services. And I will turn it over to our moderator, Kush Cooper, who is the President and CEO of Informatics. So welcome, and let's get started.
Thank you, Dana. Welcome, everyone. Thanks for joining us. I'm gonna, in the spirit of interaction, I'm gonna stop sharing my screen here, if I can find my cursor. And we will have an interaction. So as a recap from the learning forum we just had, the one that's associated with this domain, the service quality and outcomes domain, what are the topics you deal with? What are the areas that are present within this domain? Integration of your prevention metrics and programs with your existing CQI metrics and programs. What are those metrics? Both the process metrics that tell you if you're doing this thing correctly along the way, and the outcome metrics, which tell you if life actually got better for children and families. All the process improvement practices that'll take place once you see the metrics are going in a direction you don't want them to go. What does that improvement look like? And then any fidelity monitoring or evaluation or data collection or supervision that's required by purveyors of the EBPs that you end up selecting to be in your FFPS service arrival. Okay, and so you might have local evaluations for outcomes that you're interested in having. The state might have a future evaluation of outcomes. That all belongs here. And then ultimately there have to be structured processes for communications of metrics and how things are going, of tracking and reporting to hold all of this. For the CPP, you don't need to have this all nailed down. Like you do for some of the earlier topics like program design or governance. You do have to have those plans pretty much nailed down to be able to write a CPP that's accurate and implementable. But with regard to service quality and outcomes, it's more that you begin thinking through what's going to be required, and the CDSS will ask you to sign an assurance that when we do have these systems in place that talk to each other and exchange fidelity data and evaluation data, that you will adapt your local programming to support those processes when they are designed. So that's all of the work that goes into this area. Our panel is going to answer questions that were either asked at this learning forum where we discussed all of this a couple of weeks ago, or were sent in as part of registration for that forum or this Q&A session. Once we're through the set of questions that already came in, we're going to open it up for anything that came up for you during the session. So jot all your questions down. We will take questions as we go. So raise your hand if it's pertaining to the particular topic we're discussing. We're not going to be answering questions today on other topics covered in other forums, such as pair of last resort or techniques for community engagement. And if you have questions on other topics or need other guidance, we encourage you to send them to the FFPSA mailbox that CDSS has. We're going to drop a link to that in the chat. As you can imagine, they are busy worrying about implementation and plan revisions, and so they will get to it as soon as they can, but at least the question is in there and memorialized for the time being, and folks can start to research answers. All right. There's nothing else from my team. Let me just look at them. Let's get into the questions with our panelists. Okay. So the first question, and Dan Edwards, Dan, I'm going to send this one to you. The question is, what are user-friendly fidelity tools my team could use? And the presumption is that the conversation is about EBPs. For evidence-based programs, MST, PCIT, all the T's, what are user-friendly fidelity tools my team could use?
Right.
What would you say?
Yeah, great question. And I want to echo what Kush just said too. I would love to make all of this as interactive as possible. So I'll take a shot at answering. And if somebody says, you know, that's not really what I was asking, feel free, pop it into the chat or jump on and let us know. I think the short and unfortunate answer is that there aren't any. I don't think that there are quick, easy, you know, shorthand tools, user-friendly tools. Especially not if the question is aimed at, you know, finding one or two tools that will apply across EBPs, because that definitely doesn't exist. All of the EBPs are interested in a particular type of therapy or a particular type of intervention for a particular target population, right, delivered a particular way. And not only that, but the way that they then ensure that it's delivered with high quality, each one of them has their own strategy. So BSFT, for example, if your county chooses to implement brief strategic family therapy, they ask that all of the therapists videotape with family permission, videotape or at least audio tape sessions and submit those to the folks in Miami for review. So, and they've got protocols, you know, to make sure it's all HIPAA compliant, et cetera, et cetera. But obviously that's not a quick and easy, what was the term, Kush? quick and easy or
User-friendly.
Yeah, yeah. It's not user friendly. So my short answer is to recognize that all of the EBPs assess fidelity differently, and they all have training and purveyor, what we call purveyor organizations that manage that process. So your user-friendly tool is a contract with that purveyor organization for that EBP and rely on them to collect that fidelity data and report it to you.
Thank you, Dan. And you know, just if I could underline, echo, put quotes around what Dan just said about the best tool you have with regard to monitoring model fidelity is the contract you end up having between you and the purveyor of the EBP that you select. Because your team's going to be doing very little. The practitioners are likely going to be entering data.
And let me follow up, because some folks may wonder, well, who's the purveyor? So if you have a link to the Prevention Services Clearinghouse, which I hope you all do, if not, maybe we could pop it into the chat. But the Prevention Services Clearinghouse, as most of you know, is the clearinghouse to identify evidence-based programs under FFPSA. If you go into that each EBP and you look at the information that's provided on each EBP's page, there is a program development resource that will put you in touch or direct you towards the purveyor of that particular EBP. And sometimes there's more than one, but at least that'll get you started.
Great. Thank you, Dan. And Dan, are purveyors and trainers the same thing?
Yes, mostly, sort of, kind of. How about that? So a purveyor is an organization whose mission is to disseminate that EBP with high fidelity. So it involves trainers, administrators, data folks. The whole shop is considered the purveyor shop. And now sometimes the shop might be one person, but sometimes with other EBPs, the purveyor, there could be 100 people that are involved in that worldwide effort.
Thanks, Dan. Okay, so let's stay with this matter of fidelity, model fidelity, for a moment. So the next question that came in, Yolanda, I'd like you to take a crack at it. And before you do, did you have an answer to any user-friendly fidelity tools that folks in other jurisdictions around the country have shared? Or is your experience that it's all over the place?
No, I agree with Dan. Your biggest, the best thing you can do is have a really good relationship or contract with the purveyor, because they know the service and all the intricacies of the service and what needs to be collected around fidelity, and have an agreement about how you're going to obtain that information and organize that information, which kind of leads into the next question. But yeah, I wouldn't add anything. I think that relationship is really critical, and it looks different. Some EBPs have databases, and then the county or the state may have an agreement to get that data directly from that database, from the purveyor, and then do their own analysis and CQI work with it. Relationships with the trainers, but yeah, I would just totally agree with Dan with having that relationship, because it's not something your staff is going to be doing directly. But there are a few states that are doing case reviews. They had an initial relationship with the purveyor, got a really clear understanding of what the particulars of fidelity monitoring should be, and they developed their own case review processes. That takes a lot of resource, and it still requires a really close relationship with the purveyor to really understand the data you're collecting. There are a couple states that do their own case review for EBPs, or they have a university partner or some other partner that may do case reviews and look at those clinical cases. But again, the purveyor is still critical in that conversation, and it depends on the amount of resources you have to do that.
Yeah, point well taken. Folks often think it's going to be a little more cost effective to bring it in-house, and they are often surprised at how good that contract amount looked compared to what the budget is for the new office that has to do
In
it.
cases, exactly.
Yeah. Great, thanks. So Yolanda, you hinted at this, so let's go into the next question. we have a person who kind of gets that there are EBPs and there's fidelity that needs to maintain, so you get the outcomes and you can attribute the outcomes to the actual practice. They're more interested in finding out how they can use their CQI department to support that.
So I think it's all about aggregating that information, because the EBP fidelity information you're going to be collecting is going to be by case and then by provider. And you're probably going to have more than one provider providing, say, for instance, PCIT or whatever the EBP is. So your job is going to be, or your CQI department's job is going to be, how are you going to aggregate that information to really understand what's going on, not only by case, but by provider, and then by the provider community at large, and then aggregate that up to how's your CPP implementation going overall. So I think the CQI department needs to be the conduit, or to get the fidelity information, get the last session I talked about reach data, which is all the process data about how referrals are going, to get all of that information, analyze that information, and then get to the tables where you need to talk about the performance. Whenever you hear me talk, you always hear me talk about not admiring the data like my friend Kush. So you don't want to get these reports and just run reports to have reports. You need to figure out where within your county or where within your office, where you're going to talk about that data, to figure out, are you doing a plan, do, study, act process, or data-driven decision making, whatever your improvement methodology is, that data needs to come. And usually your CQI department would be running that, where you having the conversations about the performance, so that you can identify improvements, get at root causes to why things may not be going the way you want them to go, and then what are some solutions, and talking with the people that are doing the work. So with the providers, you're going to want to be having conversations with your provider community for each individual EBP and for just implementation overall. So the CQI department should be the center of analysis and disseminating that information and facilitating the conversations around improvement.
Yeah. So, and what I'm hearing from you, Yolanda, is they're not necessarily the ones with the clipboard looking through the one-way mirror, seeing how the practitioner is providing the therapy, right? The purveyor will do that. We just need to get all that data in aggregate from the purveyor who has had the clipboard looking at the practitioners.
And organize it in a way that's meaningful. If you have there was a handout from the last session, we have a measurement framework, and there's some ways that you can organize that information to make it more user-friendly for people. You may want to categorize it around process, capacity. So capacity would be things like, how is the staffing going? Is everybody licensed? What are your IT needs? What are you learning about just the capacity of your community to provide the service? And then you'll have some process measures that you want to look at, and then you may have some quality pieces. So if you look at the framework, you can see some of how we suggest you might want to organize the information.
Yeah, it sounds like there's a lot of ways to create dashboards, given the framework you provided, Yolanda.
And
Okay.
Kush, before we continue, I just wanted to point out 2 quick questions in the chat. And you can let us know. Sometimes this is the best time to answer those, and sometimes we can put them off to the end. You just let us know.
Yep, I see them. Yeah.
First question is from Regina. Should counties be planning to implement their own tool for well-being, longer-term outcome measurement, or is the state planning to set up measures that counties will be required to measure and report on?
Kelly, do you want to take that one? As the state?
Yes, that's fine. So counties can do that type of work on their own, but the state is planning on setting up measures that we would like to be reported on statewide. So when we get into that process and we're starting to do that work, counties will be invited to participate in the development of those measures and be able to give input and determine what they would like to see in the statewide measures. So yes, that will happen, and but you can also continue to do that on your own as well, if you want to do something beyond what the state is planning to do.
Great.
Thanks, Kelly. And somebody's asking in the chat too, is there a link where the document mentioned may be obtained? I'm presuming that's the framework Yolanda was referring to. And if we do have the link, it was in the last session, but if we have a link, we'll get it dropped into the chat for you.
Absolutely. And there was a kind of a question comment. And the question comment is, oh, thank you so much. It looks like that document was dropped, the link to the last question, by the way. CQI department. So it sounds like smaller counties don't have a CQI department. Didn't know if you had any thoughts or any reflections on that.
We are going to actually hold that thought, because we're going to actually get into the small county question fully as a question area. It's a great question. We will absolutely get to it.
Wonderful. And last one before we move on to the next question. Will we have already developed our contracts before state develops the measures?
I'm presuming that means contracts with purveyors before state develops the measures. Kelly, do you want to tackle that one?
And I suppose that there are some circumstances where that could happen. And, there may be some need for you to develop your contracts with some flexibility. But I mean, as long as you're developing your contracts to ensure model fidelity, I think you're probably fine there. The data that we intend to collect at the state level will be something that's available through CWS Cares. So that'll make it easier for folks to be able to participate in those statewide measures without additional changes to contracting. At least that's the expectation and intention. There may be some complexities there that we can't plan for in advance, but part of the process, we'll be hearing some of those concerns and complexities that we'll try to resolve in the development of the process.
Yeah. And Kelly, with regard to, there might be some motivational interviewing comes to mind, right? Where we can imagine that there could be some, given it's just so popular, right? There could be some ways in which economies of scale could result in the state creating some sort of more unified inquiry around how is MI working? Right. And in that case, there might be that could be one of those scenarios that you're talking about, where you might say, we don't want to use that fidelity tool. We think actually it's going to be easier for the state to use, the other fidelity tool. And I think that speaks to you saying, well, build your contracts with some flexibility, right? So that you could switch out like this fidelity tool for that fidelity tool down the road. If you needed to. Right. So while you have the floor, Kelly, I mentioned in my level setting earlier, and this is a question also that's come in, that there will be a CPP assurance, an assurance that will be attached to the CPP that a county will have to sign in this area, the quality and fidelity area. What will that look like?
So we're in the process of developing those assurances right now. In fact, I have a draft that is under review today. So similar to what the federal government has asked us to do, we're kind of passing along those assurances to counties, because knowing that a lot of the direct delivery service work will happen at the local level. So the assurances will basically be like a 1 or 2 page form that cites the federal and state law relative to these particular assurance sections. And the assurances will include about 5 or 6 different categories. So it's the Title 40 Prevention Program reporting assurance. This is the assurance that that basically says that all of the reporting requirements that are going to be collected in CWS Cares that are required by the federal government, and then whatever measures the state comes out with, the county will comply with that reporting process. Then there's the assurance of trauma-informed service delivery. There's the assurance for child safety monitoring, and then an assurance for workforce development and training, making sure that all of your staff are adequately trained according to the training program that the state is in the process of setting up. Again, this is a process that counties will have input to. As we're developing that, we want to hear from you all about what your needs are and how best to meet those needs. And then another assurance will be around model fidelity for evidence-based programs. You're hearing a lot today and in the last learning series around what that will look like. And then 2 more, we have, maybe it's more than 6, participation in the continuous quality improvement activities. We just talked about that. And then the final one is the joint protocols for the determination of funding, or the payer of last resort. So all of those are, several of those are areas where the state is still developing guidance. And so again, it'll be about reminding what state law and federal law says, and then just some expectation of following upcoming guidance.
Thank you, Kelly. So I'm going to move off the sort of model fidelity of EBP's topic, but want to give the chat one more moment in case there's a question related to this topic. Not that there won't be an open forum later where you could also ask the question, but if not, and I don't see any, let's go to the question about small counties. One was asked in the chat and one came in earlier about this, and they speak to the same dynamic, which is the question that came in is, how can smaller counties implement EBPs when they frequently do not have either the workforce or the participant numbers to support fidelity, right? And this is related to the question that just came in, which is, what, small counties perhaps don't even have the luxury of having a CQI department, right? That's going to aggregate all those data. So, what would it look like in that case? Dan, you want to start us out?
Sure. So it's a bigger question than that. And let me just frame it in a little bit of a larger context and then come back to that specific context. But if you're a smaller county, and you're looking at, this whole question of what's our target population, how many people, what do the demographics look like in terms of, where do we have gaps in our system, and all those questions that are being asked. And hopefully you'll come to a conclusion that we have the highest need in areas, A, B, and C. And that, if we match that up with an EBP, right, like PCIT or FFT or whatever's on the list, you may realize that, yes, okay, we're too small to do this on our own. But, to be able to support the high fidelity implementation of an EBP, I think that it would involve, from the start, talking with other counties or talking with other jurisdictions about partnering together to say, east, west, north, or south of us, is there another county with a similar need? And could we together sponsor a PCIT program, let's say? And I've got 4 things in that conversation then that come up that small counties have to think about. So first of all is, the qualified workforce question. And everybody always worries in rural areas about, do we have the master's level staff, the licensed marriage and family therapist or LCSWs that we're going to need, right? That's a big question. And it becomes a little easier if you're in a partnership, I think, with potentially other counties. The training, how are we going to train those folks? What's the training plan is the second question. And that one, I think, is, like I said earlier, that's the relationship with the purveyor. I also refer to them as training and licensing organizations. So these folks, talking about PCIT, you've got PCIT International, for example. The third big question is that of referrals. Once we build the program, are they going to come? And so talking with all the potential stakeholders and referral sources about ensuring that once this program, the staff are hired and they're trained and the program is stood up, that we will in fact fill up to capacity or use the available capacity. Then comes the fourth question, and I think that's where the CQI question comes in. If you've already answered the first 3, then the question about, who can manage the data questions, who can manage the CQI questions, maybe one of the counties can take it on, maybe through some sort of a partnership agreement. the 3 counties or 4 counties or however many in the partnership can pool resources to do it. But again, the primary responsibility for collecting fidelity data, and I love Yolanda's 4-point framework there between reach, capacity, fidelity, and I can't remember the fourth one, Yolanda. Outcomes, I think.
Outcomes.
The one that matters the most. Yeah. So that as you try to address those 4 questions, you're doing it in a partnership, and the information coming from the purveyor about fidelity is answering one of those questions, right? The fidelity quality question.
Dan, so would it be that, and I don't know if you've seen this, in a smaller county then that would not have the existing in-house capacity, right, to do all this aggregation and doesn't think this is the time or the initiative to stand that up, right? Would there be more outsourcing than not if you still wanted to go ahead with the particular EBP? Then you'd have to get the purveyor organization to do all that for you, or get an organization that will work with the purveyor and do all that for you.
That's right. That's right. And the purveyors are going to provide quality or fidelity data in aggregated fashion that I think will answer, most of the questions that the state would ask in that domain. How many therapists are in fidelity? So for PCIT, there's a training process, there's a review process, there's a certification process. PCIT International would answer all those questions. I think regarding PCIT, those would be the questions the state would want to know about. So it's not the same kind of thing where somebody in your staff or in your agency has to go through and review case notes or, come up with some sort of a checklist to check and see if the PCIT is being implemented correctly. That's provided by the purveyor.
And there's a great point inquiry in the chat. Thanks, Mike, for the question. And this is an answer. I give a similar answer as you, Dan, when I'm asked this question. So that it would follow from that the solution is contingent on some sort of pooling of resources or economies of scale or multi-county partnerships. Although I have heard from the small county that while they share a population number, right, which makes them a small county, they are very different, right, and have very different needs. And those population numbers may be the same, but the needs of those populations may be different. So would you say it's fair? The inquiry is it fair to say then that without a multi-county partnership, this is really not possible to do for a small county?
Without knowing the numbers, right? I don't know when we say small counties. So for example, PCIT could be implemented with a fairly small workforce. MST is 3 therapists and 15 cases for a full team at a time. So that's not a lot of kids and families that would be needed, right, to fill the capacity of an MST program. And maybe a small county could do that. MST, I know because I used to work with them. I know they have a sort of rule of thumb that somewhere between every 100,000 or 100 to 200,000 people, right, general population numbers, there's probably enough kids roughly between the ages of 10 and 18 whose behavior is putting them at risk for severe system consequences, right, incarceration or out of home placement or something like that, that probably somewhere between 100 and 200,000, general population, there's enough kids to satisfy the needs of an MST team. That's not a lot. That's not a big, I don't think that's a big, metropolitan area.
And just to add to that, bring into the floor the comment about, the small counties, you're looking at sometimes between 3,000 and 50,000. Right, if you're looking at some of the smaller ones. So in order to get to that 100 to 200,000, if you're a 50, that takes 450,000
Oh, okay.
person
Okay.
counties,
Yeah,
right?
yeah, yeah.
And then there's geography, and not necessarily that this is a question, but it's just something to put out there, which is
Right.
while the population may be small, they might be spread out often over counties that are difficult to get from, take 6 hours to get from one side of the county to the other because of the terrain, because of weather, etc.
Yeah, and that's a great question. Many of the EBPs are in-home, and therapists can travel up to 90 minutes in one direction and still be in fidelity with the model. But others, like PCIT, tend to be office-based or clinic-based. And so, yeah, it's definitely something to look at and think about.
Great. Thank you. Dana Jerzink is encouraging you all, and I want to echo that encouragement to come off mute and ask your questions or ask follow-up or clarifying questions. We want to run this a little more like a conversation than the one directional that we've been doing. So
Sure.
yeah, Monica, would you like to ask your question out loud?
Sure.
Yeah, go ahead, please.
Yeah, it came up in a conversation with smaller counties, the question of, are there any EBPs that are approved virtually to meet fidelity standards that might be a feasible solution for smaller counties to be able to utilize?
Is that a trick question?
I don't know.
It's a great question. Yeah. No, it's just so I think what I could say is that none of them thought much about that pre-COVID, right? I don't think any of us really thought that much. Some of you did. Good for you. Not the majority, I don't think, thought about virtual, telehealth, mental health delivery, large scale. And certainly these EBPs that are, doing all this research, and very, very little of the research was done on telehealth. But then all of a sudden we all had to do it, right? So what happened was, over those roughly 2 years, 2020 and 2021, they learned, and they did sort of, PDSA cycles. What about if we train everybody virtually? That's the first step, right? And then do we get good reviews from the trainees that they feel like they've learned the model, etc.? What about supervision? Could supervision be done virtually? And then of course, the actual service delivery. So far, across all of the EBPs that I've talked to, they have, basically green lighted or, thumbs up the pivot, but also now they're pivoting back, most of them. So I think I will just say it's in a learning space right now, but all signs are positive. Sorry, the reason I asked if it was a trick question, I was being cheeky, but when you use the word approved, right? Is it been approved? I don't know that anybody, I may be wrong, and maybe Kelly or Kush or Yolanda, you guys know, but I don't know that anybody at the federal level has weighed in, except to say that, yes, it's a learning environment, and yes, for now we're going to approve it. But but it's on a temporary tentative as we go basis.
I haven't heard anything. Kelly, have you anything like? Yeah, I haven't heard. Yeah.
No, it's usually the purveyors or the developers kind of thinking through, like you're saying, Dan, whether they can. I've heard some of them say, no, this can't be delivered in that way. But like you said, a lot of the EBPs are really thinking it through, like what's possible, what makes sense, and in terms of what's needed in that interaction, that therapeutic interaction. So.
Right. And the only thing I'll add at the end is that I know the ones that I've talked to also have expressed a preference for in-person, right? MST is just, especially if there's a crisis, if you've got a single mom at home, and the 16-year-old boy is broken curfew and he's coming home late, if she wants her therapist to be with her, she wants her therapist to be with her in that situation, not on the phone. So it's yes, there's a strong preference for being in person as much as possible.
Thank you. And Kush, I see a hand raised from a participant. Regina?
Yes. Yay, Regina, please go ahead.
Hey, good morning. Even as a medium-sized county that Sonoma is, we have similar capacity concerns as we think about the implementation, for all the reasons you stated, plus just that client engagement rate and client participation in services that we are thinking about. And so one of the strategies that we're looking at is being able to use motivational interviewing in a way that's with fidelity to the model, but in conjunction with an array of other services in order to be able to access a broader population. And I'm wondering if there's been conversation about that. Is that an okay path to be considering? Or is that not the intention of using MI to fidelity?
Yeah, so it's a great question, Regina. So, and I'm gonna punt it to our experts in a moment. So, but let me also make sure you're asking with the question you're asking. Using MI for something other than substance abuse treatment, i.e., for cross-cutting case management conversations, is that an okay way to start thinking about bringing MI on in the county as an FFPSA funded EBP? So that's the question I'm understanding that you're asking. Is that accurate, Regina?
Perfectly said, Kush. Thank you.
Okay, great. And just before I punt it over, know that a lot about MI came up a lot in our QA session on getting ready to deliver services.
Okay.
And fiscal when we start to talk about how to fund EBPs. And so there's a link that we're going to drop in the chat to that. And then I'll predict that the answers from our experts are going to be yes. There is evidence both that the federal government has approved it and that it's being successfully used in a jurisdiction, that MI can be used as a cross-cutting case management strategy in addition to a substance abuse treatment strategy. Yolanda, I'll take that one first.
Yeah, I'd agree. You're exactly right. One question I would ask maybe Kelly is in the state plan, is MI showing up in the state plan as a cross-cutting case management strategy?
Yes, it has been included that way.
So most definitely, yeah. And if you mentioned that there's been previous conversation about the fiscal implications for that, I think that'd be important for you to take a look at. But I think you're exactly right. Using MI in that way through the workforce. Of course, you have to think through when you're using it with your case management workforce, thinking through the fidelity monitoring piece of that too, to make sure it's being delivered appropriately. But most definitely that would be a great way to supplement some of the other services.
And
yeah,
great, thank you, Yolanda. And Dan, there's a great comment in the chat that sort of speaks to this and brings in what you said earlier about partnerships. Cindy and Humboldt stated that they're going to be implementing MI and for workforce development, and they're having the training and coaching provided by the MI initiative that's happening in Los Angeles. Right, they sort of partnered with Los Angeles to be able to again provide some economy of scale, so it's worth it to the purveyor to come on out and create a system here. Dan, would you have anything to add there about anything different than what Yolanda would say? And then Kelly, anything for you to add there? Okay. So let me make sure we get this question in. This is sort of the last official one that came in that we were planning to cover. And it's a general CQI topic, and it's related to something, Yolanda, that you just said in the conversation we're having, which is, okay, so yes, there's the EBPs, right? And that's FFPSA funded, but not all EBPs are. So there may be some non-FFPSA funded EBPs you might want to consider. And then there might be some services that aren't EBPs at all that you might want to consider as part of your overall FFPS program, right? Which is both FFPSA funded and state block grant funded prevention services across all three tiers. So the question is, And Yolanda, I'd like you to take a crack at it first. What does CQI look like for non-FFPSA services that are required or that we've selected that are then going to be documented as a required part of the CPP? Like, what does CQI look like for them? And then does the same apply to non-EBP services? So non-FFPSA and then non-EBP.
I think the broad answer is that you're going to want to monitor the core components of whatever the service is you're delivering. So with an EBP that's, in the prevention clearinghouse, you have all the fidelity pieces. If it's an EBP that's not in the clearinghouse, there's still some fidelity, I would assume, that needs to happen. So you need to understand really intricately what that EBP, what the fidelity monitoring requirements are for that EBP, what makes it tick, what's the secret sauce, and have a way to look at those things, again, in partnership with the purveyor or whatever organization is supporting that. And then for other kinds of services or other parts of the program, there's still a component that you need to look at in terms of what makes it work. What are you trying to get at? If it's a process piece, what's the process you're trying to, you still want to make sure those processes are happening. So, I mean, the general answer is monitoring the core components of whatever it is you're delivering, identifying those core components, making sure they're in line with your priorities. And I'm assuming all these EBPs would definitely be in line with those, and make sure you're collecting data on those pieces that are important, not too much, not too little. Look at the core components, and then produce those reports and have a conversation about it. Again, not just collecting the data. You're going to want to understand how things are going. What is the ongoing monitoring of implementation of your CPP? What are the core things we need to be looking at, whether, again, it's a non-FFPSA service, a case management service, an EBP, or whatever it is? What are those things we need to be measuring to understand if implementation is going well?
Yeah, and what your answer brings to mind the Indiana experience, right? Where Indiana saw that, well, concrete supports really seem to be making a difference here.
Sure.
And they're not on the prevention services clearinghouse, but perhaps there's something we still want to see it as a concrete service that we then will need to evaluate to see if it works and do CQI around, right? Not an EBP yet, not an FFPSA funded service necessarily yet, but they are going to do CQI around it because it's a core important thing for them.
Exactly.
And then, Yolanda, just while we're here, because you've mentioned about making sure you don't keep admiring the data, admiring the problems, and sit at the tables, right, and have these conversations with the people that can do something about it. What has it looked like? And Dan, I might ask you next to answer the same question. What does it look like to engage these governance structures, these various governance structures, right, that are steering these prevention programs in CQI activities, right? What has it looked like? What are some of the things you've seen that have worked? What are some of the things you've seen haven't worked?
Yeah, so making sure you have all the right people at the table, people who are delivering the services, people who are impacted by the services, making sure you got all the right voices in the room. So there was a visual in the slide deck that I used last time that looked at the county level, the county level communication pathway, if you will. So you're going to have an implementation team. You're going to have some people in your county responsible for implementation, and at that table needs to be workers and leadership. You may want court people there. Your provider community definitely needs to be there. You may want to have youth and lived experts at that table. So that's one table where the data is coming to on a regular basis. And again, you're talking about, let's look at the data. What are the root causes? What can we do to fix it? And you have all the voices there. And you may have different conversations in different places. There's some places where the agency does that internally, looks at the data, and then they have big quarterly community meetings where they engage the community, the providers, and it's a large group of folks to have just that conversation. Here's the data. Here's what it says. We've analyzed and pulled out the key pieces. Talk about root causes. What's happening? What is your experience? And we kind of break them up into groups and really try to get at what's going on, what's underlying this issue. And then what can we do about it? And then you're talking about those same things at the next meeting. So you may have those larger community conversations. You may have them in different pockets around your EVPs. You may want to pull your providers who are providing PCIT all together for a learning collaborative, because they're all providing that service. You may have seen something in the data for PCIT that's saying there's some fidelity problem. So that's going to be a CQI group to take a look at, why aren't we meeting this fidelity measure? What are the root causes? What's impacting our ability to do that? And what can we do to improve? So you can have pockets of CQI tables in different ways, but that larger community group, your implementation team, and your provider community are three of the key places where you want to have those talks.
Great, thanks, Yolanda. And then Dan, I know you've been brought in by multiple states to help them get their arms around some really large EVPs. How would you answer this question?
I'm struggling to try to figure out how to add anything beyond what Yolanda just said. Yolanda, we need to go on the road together. Man, this is like perfect. This is all about, I will say just this much, lessons learned, I guess. There are two important values in the evidence-based practice community. And I think you're talking about both of them, Yolanda. I'm just going to label them. So the first one is transparency. And that's what this data collection is all about. Let's make visible the things that therapists are doing, that supervisors are doing, that experts are doing, and capture it and make it plain to see. I love to be able to talk to funders and decision makers and stakeholders about, this is how we spent your money. Does this make sense? Do you understand what you've got? Is it satisfactory? Does it meet your expectations? Those are fantastic conversations. They're real world conversations. The second big value is accountability. And I know we talk about accountability at every level. As you have that root cause discussion and we're just sorting it out and everybody has ideas, eventually, often my experience is the group comes to consensus about, like, this seems to be issue number 1 and number 2 and number 3. And now what? And so the accountability is we write it down and we commit ourselves as a group to address those issues together. It could be that the expert or the purveyor that you're working with, they're not doing their job. Maybe they've had a turnover or somebody's not been performing at the high level that they need to perform. It could be a judge that is, or somebody in the court community that's making it difficult, and we need to go talk to them about, trying to get on the same page about what we're after here, things like that. So there's nobody who's above the law, so to speak, in these conversations. And they're very exciting, I think.
Yeah, I just add to that, it comes to mind, we are better together.
Oh yeah.
Prevention effort. I mean, if there's a motto to have, to not do this in silos, we tend as child welfare agencies, it's like, we got to get our ducks in a row first. Spread the love, have the conversation, your provider community, your lived experts, purveyors and developers, to get at that table at the front end, as far on the front end as you can, to help in the planning and the decision making and the ongoing monitoring, and not to perpetuate the silos that we tend to do in child welfare and a lot of just professional work that we do. We got to get our own little thing together, but having those conversations and making sure your workforce is also involved in those conversations, both from at the provider level and the workforce, because it's going to start with the agency, that whole referral process. So the clock starts, or the work starts there. So anyway, I'm rambling now, but just, we are better together with this to really try to upfront get all the voices at the table and keep them there on a regular basis for that transparency and accountability that Dan talked about.
Well, that's kind of one of those notes to end on. If I've ever heard one. I don't see any questions in the chat. I don't see any hands. Let me give it up just a 1/2 second in case there was somebody, like, can't find the mute button. No. Okay. So, on that note, We're going to be better off doing this together. Keep talking to each other, even though it's anxiety producing. We will send you off into your Wednesday. I'm going to turn it over to Jessica to close us out.
Great. I just want to say on behalf of the panelists today, on behalf of the participants, thank you to the panelists for being here. Thank you for sharing your expertise. Thank you, participants, for also joining and for your thoughtful questions, your comments. So a couple things to note. For the next Learning Forum topic, which is preparing the workforce to deliver family-first prevention services. That information, you can register. Perfect. There it is, right in the chat. You can log there to register right away. So if you want to continue this conversation, as always, we'll have a main topic, a main session to review with a follow-up Q&A. So you can click that link to get to Caltrin to see it. There are also some upcoming Caltrin trainings. Kush, if you want to share your screen, otherwise we could just drop it right into the chat. There are some upcoming training topics that are offered through Caltrin. Just to give you a little reminder, if we haven't met yet, Caltrin is the California Training Institute. We're funded by the state of California, the Office of Child Abuse Prevention, the Department of Social Services to provide free, professional, and think of it as development topics in 4 main domains, which include evidence-based or evidence-informed practices, direct service delivery, management leadership topics, as well as trauma-informed care. So remember that these are all funded by the state, so they are no cost to you. The topics that you see on your screen may be of particular interest to you. If they are, you are more than welcome to sign up. And again, you wouldn't submit a payment to do it, just your time. That is the form of payment we take, your time and participation. So you can click the link in the chat, which is caltrin.org, to learn more about that and to register for any upcoming trainings. And with that, we want to say thank you for your time, and we look forward to seeing you in the next series. Thank you so much, everyone. Have a great afternoon.